Hi, I'm Dr. Michael Brode. I'm an internal medicine doctor and medical director of our post-COVID-19 program at UT Health Austin, which is part of Dell Medical School at the University of Texas. And today I really want to try to demystify long COVID, what it looks like seeing patients, and what the emerging science and research are telling us about this illness. So the first thing I always start with is a little bit of a history buff, is to say that post-viral illnesses are not new. We've seen fatigue and neurologic symptoms after previous pandemics like the Spanish flu or even the original SARS virus. And so when we're talking about long COVID, it's a question of what is a virus we've never seen on this scale in modern times versus what does the COVID-19 virus cause in particular. And long COVID is probably a confluence of both of those phenomenon. I think the first part that gets a little bit confusing is what is the name of this illness? And I think most people have settled on calling it long COVID, although the medical term is post-acute sequelae of COVID-19 or PASC. Some people call it post-COVID condition, and patients themselves may refer to themselves as long haulers. Right now, there's not a consensus definition or even a diagnostic test that can diagnose long COVID, but most experts agree that if symptoms began after long COVID and there's not an alternate medical explanation for the symptoms and they're lasting more than 4 weeks, that it is probably long COVID. What we do know though is that the active initial COVID infection can last up to 4 weeks. People have rapid healing during that time. It slows between 4 and 12 weeks, and then after that the healing plateaus. So usually at about 12 weeks, the symptoms that are still there are the ones that are most likely to persist. And that's when most experts are going to say long COVID starts is 12 weeks after the initial infection. I also think that the framework of understanding long COVID can be overwhelming. Some research has said there's more than 50 symptoms, other research more than 100, and the one paper that takes the cake identified 203 symptoms from long COVID. I really organize it into 3 main categories. The first being what is damage to the body or the tissues that we can detect on our traditional tests. And so that may be lung scarring, and that is almost exclusively in patients who were hospitalized or had severe illness that required them to be in the hospital and getting oxygen. The next category is new chronic illnesses following the COVID-19 infection. And there's research to suggest that people are more likely to develop diabetes, blood clots, fatty liver disease, or stroke following a COVID-19 illness than not. And so for those 2 things, having detectable organ damage from a severe illness or having a new condition, most people don't think about those as long COVID because those are detectable problems that we have evidence-based treatments for. And most people would consider that a post-COVID condition. Long COVID, on the other hand, is more of this syndrome of symptoms in the absence of an identifiable problem on a lab test. And this is kind of the mysterious illness or strange symptoms people are developing, which we more consider long COVID. So within that syndrome in these mysterious new symptoms, I really group those symptoms into 3 categories. The first is post-viral symptoms. And so, cough, shortness of breath, having muscle pain, joint pain, or headaches, almost if people got this viral flu-like illness and it never went away and those symptoms never got better. The next category is neurologic or inflammation symptoms. This really shows up most prominently in neurologic problems of the autonomic nervous system. That's the automatic part of the nervous system, the part that controls heart rate, blood pressure, gut movement, temperature regulation. And we're really seeing that with long COVID, there can be a lot of new neurologic symptoms following the COVID infection. The last category, which is almost universal with people with long COVID, are fatigue, brain fog, and a medical term called post-exertional malaise, which just describes the phenomenon of you do an activity that normally would not be tiring, and it just wears you out, and it makes all your problems worse. And it's been my observation that those 3 things are interrelated. The fatigue is real, and that's the most common symptom of long COVID. And the brain fog, when we do formal testing, are really deficits of concentration, attention, and processing. And so on formal testing, most people can compensate and do quite well, but in the real world, it really rears its head. So the word is on the tip of my tongue, I walk into the living room and can't remember why, or just have a lot of trouble focusing. And what that looks like it seems it's very clearly related to the fatigue. And that makes sense. The brain is the most metabolically active organ in the body, so that uses and can drain the battery just as much as doing physical exercise. And the terrible thing about long COVID, if you drain that battery too much, you hit a wall and you pay for it. You experience the post-exertional malaise, and it makes all your symptoms worse. So for long COVID, there's not a discrete definition. People can have mix and match from having the organ damage to having new illnesses like diabetes to having these mysterious symptoms. It's not always perfect, but I think those categories of symptoms are what most people are thinking about when they think long COVID. Next question is, well, how many people have long COVID? And the answer is a lot. The CDC estimates that 15% of the total US population has had long COVID at one point. That's almost 40 million Americans. They estimate also that 6% of people still have long COVID. That's 15 million Americans. And right now, they estimate that 5 million people are out of the workforce because long COVID can be disabling, and there's going to be $500 billion of extra medical costs to our society. And so a lot of people are going through this, and this is going to have a lot of repercussions from the pandemic that are going to stay with us. The next question is, who gets long COVID? And while we don't know exactly for sure who is at most at risk, there's two main categories. The first is pretty obvious. The people who get the most sick and are at the most risk of getting sick from COVID are the ones more likely to develop long COVID. And so that includes people who may be overweight, have diabetes, be elderly. They're the most risk at being hospitalized and having those lingering symptoms. The next category is a little less obvious, and I kind of consider that of people's underlying immune system. And so people who have autoimmune conditions or have some low-level autoimmunity, even if they don't have a diagnosed autoimmune condition, seem predisposed to getting long COVID. People with connective tissue disorders, asthma. Also within that, women seem to be getting long COVID more than men. And once again, women are more predisposed to developing autoimmune disorders than men. So there does seem like there may be a connection there. Lastly, and I think this is an area of important research, is that people who have reactivation of viruses in the body may be more predisposed to developing long COVID. And so the big example is Epstein-Barr virus, EBV. It's the virus that causes mono. Some research shows that during the active COVID infection, if that gets reactivated and loose in the body, they are more likely to develop long COVID symptoms. Although it is important to note, when people are measured months later, usually the virus is out of their blood. And so it's unclear whether these viruses like EBV are directly causing the symptoms or they are just more part of the problems of the immune system response and inflammation from having the infection. That always gets into the next question is what is happening, what is causing long COVID, and what is the mechanism? And right now we don't know for sure. There's no diagnostic test or specific set of symptoms that diagnose long COVID. And when we can send a blood test to the lab to diagnose it and know the mechanism, that is going to be a medical breakthrough that is going to win someone a Nobel Prize. But right now we don't have it. Right now, though, the main theory of long COVID is that it is caused by dysfunction of the immune system. The immune system protects the body from threats, bacteria, viruses, but when it is overactivated, it can start to cause problems like inflammation or attack the body itself. Within that, there are some theories that there are viral fragments in the body that could be leading to that chronic inflammation, that it induces autoimmunity so the body attacks itself, or maybe there is even problems with the vasculature, microclotting, and problems blood flow throughout the body, or signaling within the nervous system. And there is some new and emerging research that actually may say all of those things are happening. We don't fully understand the mechanism. Some suggest that these viral fragments are causing chronic inflammation, which decreases serotonin and leads to problems of the neurologic signaling and even these microclots, although that's preliminary research that's going to have to be validated in larger populations. Despite not having the exact mechanism figured out, there are two things in the research that really stand out to me and show up over and over. The first is that there is clearly neurologic inflammation happening. What we're seeing is, in some research, the part of the brain that is supposed to be keeping inflammation out actually gets activated, and that's decreasing blood flow to the part of the brain that controls concentration, attention, processing, and even the memory portions of the brain. And a lot of patients describe they're in this kind of fight or flight response. They're more irritable than they have been. They have less reserve or anxious in a way that they've never been before prior to the infection. So while most people experience the inflammation on the brain, a subset of patients can also experience it peripherally on the small nerves of their body. And so those, once again, are the autonomic nerves that control heart rate, blood pressure, temperature regulation. And some studies show that those nerves can be damaged or are not working properly with long COVID. The next category of research is really looking at exercise testing, where they take young, healthy people who now have long COVID and they put them on a treadmill and see how they do. And unfortunately, people with long COVID don't do well exercising on a treadmill, but it's for a very specific reason. As they start to, move, their heart pumps the blood, their lungs put oxygen in the blood, but for some reason, the blood returns to the heart full of oxygen that the body never used. And so it's a fundamental question. Why is that? Some research suggests that it's a problem of cell metabolism. The body's got to turn oxygen into energy. Other research suggests it may be a problem of blood flow. The body's got to get the blood flow to the right place at the right time and extract that oxygen efficiently to be able to use it for energy. Like all things, probably a combination of both are happening, but what we see with people on the treadmill is that as they start to exercise, they start to build an energy deficit because they're not using that oxygen, and that tells the brain, fix it. And how does the brain fix it? Well, their heart rate goes up, they start breathing faster, they start to feel terrible in their chest and short of breath, but there's nothing wrong with the heart or lungs. It's just the body trying to deliver more oxygen and compensate for what is fundamentally an energy problem. And on these same tests, people don't do well on the treadmill on day one, but if we bring them back the next day and try again, they do terrible. They have post-exertional malaise, and they have less exercise capacity after they build that deficit. Finally, how do we approach patients with long COVID? And my first step is always to believe the patient. It is absolutely a real illness affecting millions of Americans, and it's important to recognize that because it seems to be affecting women and women of color more than other people, and that is a group that doctors and the medical community have diminished their symptoms or disbelieved historically. And so we just need to be humble, even though we can't explain it. This is an illness that is real, affecting millions of people, and just listen to the patients. Next is that we really need to make sure that it's not other medical problems causing this condition. Heart disease, diabetes, thyroid problems are common in the general population and can overlap with a lot of these symptoms. So it's important to make sure those things aren't causing the problems, or if you have those problems, that they are well managed and not contributing. The next step is screening for mental health symptoms. I would argue that anxiety is part of the neuroinflammatory response of long COVID, and depression is just part of being alive over the last 3 years. But, whether it is physiologic from the virus or just, dealing with a chronic and disabling disease, without dealing with the mental health symptoms, we're not going to have a foundation for recovery. And that also gets into people's social lives and their financial needs. Once again, this can be a disabling illness, and if people are worried about losing their housing, losing their job, and we're not caring for those needs, they're not going to have any foundation to build their recovery on. The last part is that I do want to offer some good news. The statistics show that most people are getting better. Remember the CDC, if we went from 15% of people have had long COVID to 6% still have it, that suggests that 60% of people have gotten better. And so most of that healing, in my experience, happens within the first year to year and a half. And for even the people who don't fully recover, within that time, they are certainly getting better. And so time is a healer for most people. And that really managing their long COVID symptoms by managing that energy, not hitting that wall of post-exertional malaise, doing some intentional rehabilitation or symptomatic treatment can really be beneficial at managing the symptoms while all the researchers around the world are trying to find the one curative treatment. And so the research is preliminary, but I think we're making progress and really too seeing a lot of patients get better. So thank you so very much for listening.